Thank you, everyone, for joining us tonight. I'm here with Dr. Joshua Hornstein. He's one of our sports medicine surgeons here at Rothman Orthopaedics. I'm going to give a brief introduction, and then he will get started. As he goes through the presentation, if you have any questions, please feel free to put them in the chat below. Look for the box that says Q&A, and at the end, we'll review those questions. We do ask that you keep them to a general topic rather than something specific to your own situation. We just try to keep it nice and general. If you do have something that you need to address specifically, you can always email me. Everybody here should have my email and my phone number, and I will also put it in the chat. And I can have the question answered for you. We can set you up with an appointment for Dr. Hornstein. But again, just try to keep them nice and general. So we'll go ahead and do our intro. So Dr. Hornstein is a board-certified sports medicine orthopedic surgeon. He specializes in injuries of the shoulder, knee, and hip. His clinical interests are rotator cuff injuries, shoulder dislocations and instability, anterior cruciate ligament injuries, and the treatment of hip impingement syndrome, labrum tears, and gluteal tendon tears. He serves as the orthopedic team physician for the College of New Jersey and provides orthopedic care for Lawrence, Northern Burlington Regional, and Nottingham High Schools. He has been a clinical instructor for shoulder arthroscopy at the Orthopedic Learning Center in Chicago and has given numerous local and national lectures on both hip preservation surgery and rotator cuff repair. Dr. Hornstein sees patients in our Bordentown, New Jersey office, our Hamilton, New Jersey office, as well as our Pennington, New Jersey office. And with that, I will turn it over to Dr. Hornstein.
Thank you very much.
Thank you.
Good evening, everybody. I'm going to go through just some general shoulder topics. Again, as was said, if you have questions, please leave them in the chat, and we have plenty of time at the end to go over any questions you may have. Let me get started here. Okay, so the title of the shoulder is The Amazing Shoulder Diagnosis and Treatment. Okay, this is what we're going to talk about, basic anatomy of the shoulder. We're going to talk about some etiologies of the shoulder problems, such as the pathology of shoulder, how we diagnose and treat, and then at the end, we're going to talk about some emerging technologies. Okay, so the function of the shoulder is to connect basically the arm to the body, connect the axial to the appendicular skeleton. The shoulder allows a large range of motion for positioning your hand and space to function, and it has multiple supporting structures. And as I always tell people, the more supporting structures there are in a joint, the more risk there is for injury. The articulation of the shoulder is called the glenohumeral joint. Glenoid is the socket of the shoulder, and the humerus is the ball of the shoulder. The bony landmarks are the coracoid, which is that very awkward, kind of uncomfortable area in the front of your shoulder. The acromion is the roof bone of the shoulder, and the greater tuberosity is the bump right over here where the rotator cuff attaches. And then the acromioclavicular AC joint is between the acromion and the clavicle, the collarbone, and that's a joint as well. There are ligaments in the shoulder, and there's also joint fluid that causes adhesion and cohesion between the ball and the socket. The rotator cuff, those are the four main muscles around the shoulder. They move the shoulder in space, so they function to bring your hand overhead into functional positions. They also stabilize the shoulder with relaxation and contraction, and deconditioning of the rotator cuff muscles can cause shoulder dysfunction or be an effect of something else that's causing a problem in the shoulder as well, period. So ligamentous, the joint capsule, these are the ligament structures, very thick, vigorous structures of the shoulder because it is basically like a golf ball and a golf tee, the ball and the socket joint. We really need very strong ligaments to stabilize the shoulder. And the primary functional position is the throwing position or 90-90 position of the shoulder. That's where the ligaments kick in and basically tighten. That is called the inferior glenohumeral ligament complex, or IGHLC. That is, they act as check reins like any other ligament attaching between two bones, stabilizing the joint. The labrum is this, it's not red in real life, it is in this picture, but it is actually white. It is a bumper cushion. It basically deepens the socket by about 40%. So the analogy I give people is if you took a bead of caulk and ran it around and got the golf tee of the shoulder socket, that is what the labrum does. And the ligament is also attached to the labrum. So when you have a labrum tear, you essentially have a ligament tear on one side. The long head of the biceps sits up here at the 12 o'clock position. It comes from the labrum, and it is one of the two parts of the biceps. It can compress the shoulder, primarily in the throwing position. So it's very important structure for overhead athletes. Let's talk about arthroscopy. Arthro means a joint. Scopy means scope or camera. So it's basically putting a camera inside a joint. We use a fiber optic camera. We pass instruments through small incisions, and we use this camera to see what we're doing. And this decreases the problems with surgical incisions. So basically, we're working from the inside out versus the outside in is how arthroscopy works. Okay, the portals or little incisions we make around the shoulder is actually probably about 10 or 12 of them around the shoulder. We can look from different locations. We can also put little plastic tubes called cannulas into those portals, and they can keep those space open so we can work back and forth between those spaces. We can put in implants to repair things. We can also put instruments in to repair things as well. So why do we do arthroscopy? For in the joint, in the glenohumeral joint, there are labrum tears. There are loose bodies of cartilage and bone floating around. We can fix dislocated shoulders through arthroscopy by repairing the labrum. The space above the rotator cuff, we're going to talk about a little later, called the subacromial space. Sub means under, acromion is the acromion. So it's the space underneath the acromion, which is where the rotator cuff lives. We can take care of rotator cuff tears. We can take care of bone spurs and arthritis in the collarbone joint. And then we can take care of frozen shoulder in both locations. So we want to look, basically, when we're looking in the shoulder, we want to do a 360-degree evaluation of the labrum all the way around the socket. We want to look at the biceps attachment and its insertion. We want to look at the undersurface of the rotator cuff, and then we want to go up in the space above the rotator cuff, which is the space we call the subacromial space, which is where the subacromial bursa sac lives, and also the rotator cuff on the bursal side of the rotator cuff lives. So let's talk about some pathology and how we treat things. First, we're going to talk about MRI, which most people are aware of. Oops, sorry. It's an ever-developing technology. So as essentially what we're doing with what they're doing with an MRI is taking a very strong magnet and arranging the hydrogen atoms in your body in different alignment, and then taking pictures of those hydrogen atoms. And they have different appearances based on how the magnet is run in the machine. So we get different slices. In this view, we get the front view, the coronal view, like a crown. Then we get the axial views looking straight down the shoulder. And then we always have to take the MRI and correlate it with the examination and the history. And we don't want to ever treat the MRI. We want to treat the patient. So let's talk about shoulder instability. That basically means the shoulder, which is an inherently unstable joint when somebody dislocates their shoulder. So it can be traumatic or atraumatic. It can be one direction or multi-directional. And you can see here, there's a labrum tear right here, this little area right on the front of the shoulder socket. So we want to know how many dislocations has somebody had in the past. Is this their first dislocation? Is this their 25th dislocation? It really matters what we're going to find anatomically. We want to know what sports they play. Do they play a contact or collision sport? And they want to know if they have any related medical conditions that make for ligamentous laxity, such as Ehlers-Danlos syndrome or generalized ligamentous laxity syndrome. We want to look at their shoulder. For example, here's one where thumb to forearm testing. Everybody can try that. I can't do that, but this person can, which usually is an indication of ligamentous laxity. We want to check their range of motion. We want to check their strength. We want to check their neurologic function. There can be a compression of one of the nerves in the shoulder. We want to do this provocative test right here called the apprehension test. I do it with the patient sitting up, but sometimes you can do it with laying down as well. And if the shoulder feels like it's going to come out of place, that would indicate there might be a labrum tear or from a history of dislocation in the front of the shoulder. So we always want to do x-rays. Sometimes people can have fractures associated with instability of the shoulder, either acute or chronic. We want to do MRI with or without contrast in the shoulder joint. So you have to remember that a labrum tear, like we're looking at right here, is the same as a ligament tear. The labrum disrupts on one side, usually the socket side, the glenoid side of the shoulder. And then we can have slap tears like we have right here, where there's a little superior labral tear. And this little triangle, this little white line indicates a labrum tear. So sometimes there can be a tear of just the front part of the shoulder. It can be all the way around the entire shoulder. It can be 180 degrees, the inferior portion of the shoulder. And then over the age of 50, we are very concerned with the dislocation with a rotator cuff tear. We don't see labrum tears as much. We see rotator cuff tears over 50% of the time. So not every unstable shoulder needs surgery. I'm a good example of that. I dislocated my shoulder 3 times before the age of 30. Never had surgery because what I do for a career was not available back then. So you can treat that conservatively with a physical therapy home exercise program, sling for a few days. And then surgery, really, we're doing mostly arthroscopic surgery these days. Once in a while, we'll do an open surgery, but 99% of what we do now is arthroscopic surgery. And when do we do surgery? It's really based on the history, physical examination, the risk of re-injury. Is this a football player or a hockey player that's going to have a high risk for re-injury? Is this the first time excuse me, first time dislocation. Open surgery is the gold standard, and arthroscopic surgery is really the new gold standard. Okay, so what do? We basically go in there arthroscopically, we fix the labrum, we repair the ligaments back to the socket of the shoulder with little anchors that are, nowadays, they're all made out of suture, so there's no more plastic or metal anymore. We usually immobilize somebody in a sling like we see on the lower right here for about 5 weeks. We use a cryo cuff or ice water cuff for cooling the shoulder after surgery. Pain medication is very short term, and then we start therapy usually about 2 weeks after surgery, and then some earlier if we have an older patient over the age of 25. So let's talk about arthritis, which can be one of the sequelae of shoulder instability. It's relatively uncommon compared to hip, back, or knee arthritis, but it does happen. It can be post-traumatic, like for example, somebody's had multiple dislocations, like myself. I now have post-traumatic arthritis in my shoulder. It can be from surgeries. Some of the older procedures for shoulder instability over-tighten the shoulder and could make the shoulder too tight. And it can also occur with chronic rotator cuff tears. So you can see here, there should be a nice clear space between the ball and the socket joint here, and you can see that there is no space here, and there's essentially bone-on-bone arthritis here. So this doesn't always need surgery. This can be treated with anti-inflammatories, steroid injections, off-label viscosupplementation, which is glucosamine and chondroitin gel injections, sometimes physical therapy, and then if people want to decrease their activity level, they can do that as well. For younger patients, I will do arthroscopic debridement, where we go in there and clean up the arthritis. If you look here, there's bone spur on the bottom called a billy goat spur. We can go in there and take that bone spur off, and that oftentimes will give people a little bit more motion. For people under the age of 60, usually that's a reasonable option to try. Over 60, we'll usually consider either shoulder replacement or a reverse shoulder replacement, which would be for somebody who has a chronic rotator cuff tear. This is done through open surgery. There's no way to do this arthroscopically. We replace the humerus with metal and the socket with plastic. Sorry, I can't see the socket here because it's made out of plastic. We get moving early with range of motion. It usually recovers about 6 months. It's very good for pain relief. Function is pretty good. It's not quite as good as our hip and knee replacement colleagues get. All right, let's talk about fractures of the shoulder. You can have basically the ball and the shaft and the areas where the rotator cuff attach are basically 4 different parts of the shoulder. You can have a 0-part fracture where the fracture is non-displaced versus all the way down to a 4-part fracture, which is where all 4 pieces have moved at least 1 centimeter from where they're supposed to be or angulated 45 degrees. And we treat these differently based on how many fracture fragments there are. I would say that 90% of these or more are non-surgically treated, meaning we put the persons in a sling, we get them moving with therapy, and they recover in about 6 months. About 10% are surgical. We really try to save these if we can, but sometimes they're so broken beyond repair that we have to do a replacement or a reverse replacement. So this is called open reduction internal fixation, where we put a plate with screws. The screws actually lock into the plate. So if you imagine holding a basketball on your fingertips, that's how these plates work. So they basically hold the ball out to length. This has always been a notoriously bad area for surgery up to about 20 years ago when these locking plates came into existence, and they really changed things as far as how we do the surgery. We usually immobilize people for about a month. We want to get them moving early, but we do want to protect the rotator cuff attachment sites, which is the tuberosities, which are the bumps on your shoulder. Usually takes about a year to get over this. And there is always going to be a little bit of functional loss. No matter how good a job I do fixing it, there's always a little bit of functional loss, unfortunately. And these are really life and limb altering injuries. The higher part, the 3 and 4-part fractures, can be permanently disabling. And usually younger patients do better than older patients with these, but we can also get away with a little more with some of our older patients as far as non-surgical treatment is concerned. Okay, let's talk about clavicle fractures. Actually, the most common fracture around the shoulder. You can see here on the right, the deforming forces, the muscles of the neck pull on the medial fragment, and then the weight of the arm pull down on the lateral fragment, and you can get displacement. You can see here, and this is what we call a butterfly fragment, which is where all the force dissipates. And this is a 3-part fracture that is 100% displaced and shortened. So again, clavicle fractures, 90% or more we can treat conservatively. This was actually the first bone in the body to have its own plate, own hardware developed specifically for that body part. So these plates that we use are specifically made for the clavicle. They have different curvatures, hard to tell here. This looks pretty straight, but it's actually shaped like an S if you saw it from above. So when do we operate on these? 100% displaced, meaning it's like this, and then it's shortened at least 1.5 centimeters. And then we usually get these fixed pretty easily, and then get moving pretty quickly with these. And recovery is about 3 months. They have a very high success of healing. A fracture like this treated non-surgically has a very high rate of not healing appropriately, either doing what we call a malunion, meaning it heals malaligned, or it doesn't heal at all. All right, let's talk about separated shoulders. So this is really a dislocation of the acromioclavicular or AC joint, but we call it a separation to differentiate from a glenohumeral joint dislocation. So we have grades 1 and 2. These are based on what ligaments or structures are injured. These are typically treated non-surgically, and we get early moving, and the usual recovery is about 4 weeks. Grade 4s through 6 are higher level injuries, and these usually require surgery to reconstruct the ligaments. And then grade 3, we can kind of go either way, and that's based on a patient-to-patient basis. All right, how we treat these now, we use a donor graft to make new ligaments to stabilize the clavicle, and then we use a metal button to statically fix the graft in place. And unfortunately, there's a lot of different procedures for AC joint separations, and anything in surgery that has multiple procedures, usually none of them work very well. I would have to say that this procedure that we're doing now seems to work relatively well. This can be done either open or arthroscopically assisted, and it does seem to work relatively well with good outcomes. Okay, let's talk about frozen shoulder, or also known as adhesive capsulitis. Basically, it is what it says. It's a stiff shoulder. Most commonly happens idiopathically. It can happen with people who are diabetic or people who have any kind of endocrinologic disorder, such as hypothyroidism or women around menopause. It usually comes on slowly and surely. It usually takes a couple months to set in. It can be idiopathic, meaning it just happens. It can be post-traumatic if somebody has a fall and injures their shoulder or starts a process going where they become stiff, or it can be a post-surgical. Those are the most difficult ones to treat. It's classically defined by decreasing motion with increasing pain. The 3 stages, which are not very scientific, but are freezing, frozen, and thawing. And again, physical exam is marked decreased range of motion, especially with rotation of the shoulder, external and internal rotation. Strength is usually normal, and it can often start out as impingement syndrome, which we're going to talk about next. Okay, again, 95% or more of these we can treat without surgery. Usually we treat it with anti-inflammatories, steroid injections. Physical therapy is the hallmark of treatment. And then the 5% of people who don't get better with better conservative means usually will do a release of the ligaments in the shoulder called a capsular release or capsulotomy. We do that arthroscopically, and after we do it, then we do manipulation secondarily to get the shoulder motion back, and then people start physical therapy the day after surgery. I know we're not cruel, but it's kind of strike while the iron's hot, and you want to get it really moving 3 to 4 times a week, starting the day after surgery. One of my patients once told me it's not no pain, no gain. It's the pain of gain, meaning it hurts, but you are getting improved range of motion with it. There is a thing called a dynasplint, which is a dynamic stretching splint. It's like a big spring. And what it does is it basically dynamically stretches the patient's shoulder over time. So we do that in conjunction with the physical therapy, seems to work quite well. All right, impingement syndrome is the most common thing I see in the office. Basically, it means what it says is pinching of the rotator cuff and the rotator cuff bursa by the roof bone or the acromion of the shoulder. There can be some aging factors, they'll call tendinosis of the rotator cuff. And it usually is associated with pain with overhead activity, some weakness, usually like a dull toothache, but it usually does not wake you up at night unless you roll over on that shoulder. It usually comes from repetitive overuse or bad shoulder mechanics, and there are some underlying anatomical variants of the acromion where you can get a bone spur or a hook under the acromion that can pinch on the rotator cuff. It typically has normal range of motion, unlike a frozen shoulder. Okay, it is normal strength. We do the Hawkins sign and the Neer sign. These are the two exams that we do to diagnose it. We want to do AC crossover tests to reach over to see if there's any AC joint arthritis. And again, we always want to watch for a substitute or a concomitant frozen shoulder that may be developing. Again, this should really be like 99% of the time this is treated non-surgically. I probably do 2 to 3 surgeries a year for this problem. It's very rare. We usually start with anti-inflammatories, home exercise program, and a steroid injection. And then surgery is a subacromial, arthroscopic subacromial decompression, where we I'm going to show you what that looks like next, where we take out the bone spur on the roof bone. So again, just to talk about the subacromial space or subacromial bursoscopy, it's the most common technique. We basically go from the shoulder joint up into the bursa space. We put our camera there, fill it up like a water balloon, and then we can remove the bone spur where this red line is off the acromion so it doesn't pinch on the rotator cuff anymore. This is oftentimes done in conjunction with a rotator cuff repair. So you can see here as we're using our burr, we have this little overhang, then we flatten it out so it doesn't rub on the roof bone or on the rotator cuff anymore. We get people moving very aggressively quickly. There's no immobilization time, a sling for a couple of days. Usually it's about a 3-month recovery. That's about the shortest recovery in the shoulders, about 3 to 4 months. Rotator cuff tear. This is the most common surgery I do in my practice. Usually it's people 40 and up. It can be acute or chronic from a fall, typically fall down the stairs or grabbing onto a railing or falling off a ladder. Those are very common ways to do it. Or it can be from wear and tear over time. Over time, the tendon becomes degenerative and can thin out, and eventually you can get a hole in it. And that's what we have right here on the right. Signs and symptoms, usually anterior and lateral shoulder pain. There is weakness, especially with this test to the right here. This is my go-to test for rotator cuff tear. If somebody is weak with external rotation, that's very typically a sign of rotator cuff pathology. Night pain is classic, where I would say you could be sleeping in a headstand position. The rotator cuff tear is going to wake you up. It doesn't matter if you're laying on the shoulder. We want to look at the shoulder. Sometimes you can tell chronicity. See, this person has a lot of atrophy in their shoulder here. It indicates a chronic tear. We want to check the range of motion. We just want to check the range of motion and strength, especially with external rotation, like I'm seeing here on the right. This is a classic rotator cuff tear. You can see the ball, the glenohumeral joint here. The rotator cuff is here. This has torn. This is an acute tear because there's a lot of fluid around it. This edge of this tendon should be all the way over here to the right. So see how far it's displaced. Partial tears can be part of a normal aging process, but a full thickness tear is the most common tear that we're operating on, where it's all the way through the tendon and there's a hole in the rotator cuff like this one here on the right. So these do not all need surgery. Sometimes we can get by with physical therapy and injections and medications, usually typically older patients. Unfortunately, for people under the age of about 75 or 80, these usually require repair where we go in there arthroscopically. Typically, I do that. I haven't done an open repair in about 5 years, but arthroscopic repair. And we repair the rotator cuff back to the humerus. We oftentimes use biological augmentation to help if there's a dysfunctional tissue. And if we get on somebody who has an acute tear less than 3 months, they typically do better if it's longer than 3 months, because what happens, like that gentleman I showed in the picture, when the rotator cuff has been torn for a long time, the body takes the muscle tissue and moves it elsewhere because that muscle is not working normally because the tendon is torn. And sometimes just because I plug it back into the humerus doesn't mean it's necessarily going to put all that muscle tissue back. So we want to look at the shoulder joint first. We want to make sure there's nothing going on with the biceps tendon, which again, we'll talk about in a little bit. We want to go up in the subacromial space, do our bursoscopy and arthroscopy up there, and then we'll move the rotator cuff and put it back to the humerus. You can see right here, this is how we do it. We link anchors together with sutures. So there'll be sutures crisscrossing across the top of this rotator cuff, kind of like you would lash a roast, essentially. And that's how we repair it back to the bone. And then we want to do that subacromial decompression, take the bone spur out so it doesn't rub on the rotator cuff and cause a re-tear. So we usually do a sling immobilizer for about 5 weeks, ice therapy for the first 48 to 72 hours. And then we'll start therapy as early as a week if it's a frozen shoulder, or up to 21 days if it's a massive or a re-tear, massive tear, we want to go slow with those. But typically average rotator cuff is about 2 weeks after surgery, we'll start therapy. We want to do passive motion for the first month or two. Then we want to do active assisted range of motion against gravity. And then we want to progress strengthening. It really takes about 6 months to a year to get over rotator cuff. And I tell my patients when I see them for the first 6 months, and I say, you're about halfway there. And it really is little things. It's endurance. It's doing repetitive activities. That's why it takes a year to get over this. But anybody can do anything once at 6 months, but it really takes them a year to get over the surgery. Okay, let's talk about the biceps. Remember, we talked about the long biceps. Bi means two. There's two tendons. There's the short head, which is right here. The long head is the one that goes into the shoulder joint. We're talking about the long head of the biceps. You can have a tear of the biceps where it degenerates because it sits right next to the rotator cuff. You can have a dislocation. It sits in a little groove. It can pop out of the groove from a trauma. We want to do Speeds and Jurgen's test and bicipital groove pain. This is what the doctor's showing down here on the lower pictures. And that's a classic exam for the biceps. It very oftentimes goes along with rotator cuff probably we're doing something with the bicep tendon about 15 to 20% of the time when we're doing a rotator cuff surgery. So for tendonitis, we can sometimes do a diagnostic injection with cortisone. If it ruptures in isolation, if somebody ends up with a Popeye muscle, you may have seen that in somebody before. We try to treat that non-surgically if we can. If there's a dislocation, we'll treat the associated pathology, which usually goes along with a rotator cuff tear. And we usually do what's called a tenodesis, where we cut the biceps and move it to the front of the shoulder through either arthroscopic means, or we'll make a small little incision under the armpit, right under the chest muscle, and we'll move the biceps into the humerus from the glenoid. This is usually associated with a rotator cuff tear. The recovery time, usually the rotator cuff takes precedence. If it's in isolation, we'll get moving with the shoulder. We don't do any active biceps, which is basically turning a doorknob or flexing against resistance in the elbow for about 8 weeks. Okay, let's talk about emerging technologies. We will have bone graft substitutes for our fractures that help conduct and induce bone to grow. We have biological enhancers for rotator cuff. We have platelet-rich plasma, stem cells, which are somewhat unstudied in the rotator cuff. We have bone marrow aspirate, which basically can take bone marrow out of the humerus, inject it around the rotator cuff. We have other matrices that we can inject around rotator cuffs that we can use to enhance healing, especially in a tissue that looks like it may not heal so well. We have biological cements where we can actually it's a coral type material. We can actually mix it and put it into a fracture, and then it turns into essentially like bone cement. But it's biologic and bone will grow into it. We have scaffolds that we can put over the rotator cuff or on top of the rotator cuff to try to enhance its healing. Okay, so just in conclusion, shoulder injuries are very common. Keeps me very busy. Initially, conservative treatment is but surgical treatment is important. But most things we can start with a non-surgical means. Our outcomes are getting better with improved technology. With our biologics are really helping a lot. That's been a big game changer over the last 10 to 15 years. Rehabilitation understandings are really important as well. And then I think, again, like I said, biological enhancement is really where we're going in the future, where we can do a nice repair and we can put some biological materials in there or into the repair to try to really help enhance the healing. And better things heal, typically the better our outcomes are. Thank you very much. Okay, that's a good question. So many people have partial rotator cuff tears on MRI. Typically, what we're looking for is if it's more than 50% of the attachment site. So the rotator cuff attaches over a surface area. So it attaches over a surface area like this, not a spot weld, but over a surface area like this. So when we get a tear that's either like this or like this, 50% or more, those are the ones we typically want to repair. Now, those are hard to sometimes tell in an MRI because the technology is still not great at visualizing, 51% or 49%. It's not ideal. But also, again, if somebody has tried conservative treatment, medicine, cortisone injections, physical therapy, and it's been 6 months, it hasn't gotten better, and they have a partial tear, they probably either have a small full thickness tear that the MRI is not picking up, or it's a true partial tear that's symptomatic. And some of these higher percentage partial tears can act just like full thickness tears with the night pain, the weakness, all those kind of things. So that's how I decide on a partial tear. If somebody has really tried all conservative care and it hasn't gotten better, and we have an MRI that diagnoses it, we go and fix it. So sometimes we can fix those with either taking the tear down and doing a full thickness tear, or we can leave it intact and repair the rotator cuff back to the bone, the part that's torn. Really depends on the quality of the tissue and the age of the patient.
What is the average recovery time after rotator cuff arthroscopy surgery?
It typically, I tell patients it's 6 months recovery. It takes a year to get over the shoulder, the surgery itself, but typically people are feeling better within about 3 or 4 months, 6 months before I discharge them. But I tell them, be patient. It might take a year before you can do everything you want to do.
Please discuss the 10-jet versus 10x non-invasive procedures and when one or the other is best used.
I'm not that familiar with either one. I mean, I know what those are, but they really don't seem to have a lot of place in the rotator cuff. Maybe for tendinopathy, you would consider doing it. I have seen people have that procedure done on other tendons, and unfortunately, sometimes when it doesn't work, it just leaves a big hole in the tendon, and that's not ideal. So I'm not a big fan of that. I'd be more inclined to have somebody go for either PRP injections or some kind of biologic instead of doing the 10-jet or the 10X procedure.
I had rotator cuff, frozen shoulder, and a torn labrum surgery 15 years ago at 55. Now at 70, having pain in the shoulder that had surgery. Is that arthritis?
It could be. The only way to know for sure is to come in and have an X-ray and take a look at it. But that is very common. I have seen a handful of people over the years come back with post-traumatic arthritis, especially if they had a traumatic rotator cuff tear. I don't know your situation from 15 years ago, but that is very common to have some arthritis after rotator cuff surgery, and that can be diagnosed usually on an X-ray and sometimes on an repeat MRI. It could also be other things that be causing pain 15 years afterwards if the rotator cuff in fact healed. The biceps tendon, which I showed, typically it's either biceps tendon or arthritis. Typically, if the rotator cuff is healed, it's going to stay healed. But the biceps or osteoarthritis are the two most common things I see. I've been doing this for 23 years. When people come back from 20 years out from a rotator cuff, those are the two most common reasons why I see them. And it's rare they come back, but when they do every so often, that's typically what it is.
Why do they not repair the rotator cuff, but do a total shoulder replacement instead?
So you're probably referring to a reverse shoulder replacement. That is done when the rotator cuff is irreparable. So that's typically we try to repair the rotator cuff. My rule is always keep your own body parts as long as you can, because once you replace them, there's no going back. So we really try, if it's a repairable rotator cuff, we will try our best to repair it. Even if we get a 50% repair or 75% repair, the rotator cuff has a little bit of excess capacity. I've had numerous patients over years where we can't repair the whole rotator cuff and we get an excellent result. I had somebody I just discharged to, we got about a 75 or 80% repair, and he's at 5-6 months, he's playing golf. He's really happy. So I couldn't get the whole thing back, but we got him back enough that he is very, very happy with it.
Great. MRI question. With shoulder MRI, are you okay with open MRI versus traditional or wide bore MRIs?
I would always try to encourage my patients to take a Valium and do a closed MRI versus an open MRI. The open MRIs are not great, and they can sometimes lead to a false positive read or a false negative read, and then we head down the wrong path. So to me, I'd rather give somebody 1 or 2 Valium, get themselves a ride home, and go get the closed MRI if they can tolerate it. If they really, really can't tolerate it, we'll manage with the open MRI or the extremity MRI or the stand-up MRI. But ideally, the gold standard is going to be that wide bore, regular 1.5 or 3 Tesla unit is going to be the ideal one. We don't have MRIs, but there are numerous ones in the Mercer Bucks County area that are excellent.
What are the best types of exercises to preserve or build range of motion in the shoulder?
The best ones are the small, low weight exercises. I mean, I can show you a couple. It's basically the front raises, the sideline, and going like this with, again, for normal people, 1 to 5 pounds. You don't have to go crazy. Front raises and side raises. Those are working the rotator cuff muscles compared to your chest muscle, and your deltoid and your lat muscles are much smaller. So you don't need heavy weights to do. You can basically get away with 1 to 10 pound weights, depending on the age of the patient and their overall muscularity.
Okay. Is biologic treatment pre or post surgical or both?
I mean, I have people who come in, they've tried PRP for people with other doctors. We do PRP as well if so needed. But I usually use the biologics these days because they are really relatively expensive. If I have somebody that either has very questionable tissue on the rotator cuff, or if I have a re-tear, which fortunately only happens to us about once or twice a year out of about 100 repairs. So it's relatively infrequent. I just had one, unfortunately. We went in, we re-repaired her. I put a biological extracellular matrix material in, kind of like PRP material in with the rotator cuff after I finished up repairing it. We dried out, because we use water to distend the shoulder joint for surgery. We dried out the shoulder, and then we put the gel material in on top of the repair. So that's usually when I do it. But PRP is absolutely a reasonable option for people. Sometimes it helps. It's not going to heal anything. The rotator cuff will not heal on its own. But if it's a partial tear, sometimes people, or a full thickness tear, sometimes people get relief by changing the environment to a more positive environment for the rotator cuff.
Can you talk about supraspinatus
Very good.
tendinopathy?
Yeah, well
Did I
said.
say that right?
Yeah, perfectly. That is basically the aging of our tissues. So that is very common. If you did an MRI on 100 people that were 65 years old, probably about 30 of them will have rotator cuffs. The other 70 would have tendinopathy. It's very common. Sometimes it could be in the face of a small rotator cuff tear that doesn't get picked up on MRI. But rotator cuff tendinopathy or supraspinatus tendinopathy typically occurs with the aging process. Some people more than others. I just had my neighbor. She's a fitness person. She's a trainer. I got her MRI. She's like 57 or 58. It was like the worst tendinopathy I ever saw. She got a cortisone shot. Fortunately, she got great relief with that. But we usually try to treat that non-surgically if possible.
If you injure your shoulder and know it's not a bone issue, what is the best diagnostic tool? Probably.
Well, again, first X-rays always, because it might be a bone issue. Because we have people all the time that walk in that think they just bruised their shoulder, and we get an X-ray, they have a fracture. MRI is still the best diagnostic tool. I mean, obviously, I have to listen to your history and your exam, and we're always taught history, physical exam, X-rays, special diagnostic studies, which I would consider MRI in that category. So we try to take it in a stepwise fashion and not just go right to the MRI. But again, somebody comes in, they fell off a ladder, and they could lift their arm up before they fell off the ladder, and now they can't, and they can't sleep at night. That's all pointing towards a bad shoulder injury that usually needs an MRI, because that's usually going to be a surgical problem.
Do you have any feedback on supplements such as glucosamine, or are they more studied to treat osteoarthritis and other joints such as knees? Can they be relevant to shoulders?
They can be. I'm not. If you asked me this 15 years ago, I would have said the oral supplements seem to help. I'm just not sure if they really make a difference, whether they're placebo. Because my big issue with a lot of supplements, you don't know what you're getting sometimes, or a lot of the time. So I'm not really sure if they really do help. Or again, placebo effect's a great thing if it does work, and as long as they cause no harm. Then if they make you feel better, then take them. However, they are mostly studied in the knees. You're absolutely correct. We do them between the guys I work with. We probably do in our 3 little offices that we're in, and that was mentioned previously. We probably do 25 of them a day between all the doctors or more in the knees. It can be done in the shoulder. It is what we call off-label, meaning that the FDA has not approved it for the shoulder, but because I'm a physician, I can do that. The only problem is that it costs, and they typically cost about $1,000 for a series of 3 injections between the injection and the medication. Medication's about $700 for the 3.
Right, and insurance isn't going to cover
Insurance
that,
does
right?
not cover that. So yes, so I have a handful of people that I've treated for years on the glucosamine injections, and they seem to do well with them. Once in a while, one will fall off and get a shoulder replacement, but they really seem to do well. And the knee patients, probably about 2/3 of those are on long-term, meaning over a year or more. I've been treating them with the glucosamine injections in the knee, but orally, I'm not quite sure.
Great. Can you talk more about impingement syndrome symptoms?
Typically, it's going to be pain with overhead activity, pain while lying on the shoulder at night, to differentiate a rotator cuff tear, where wherever position you're laying on, it wakes you up at night. Rotator cuff impingement typically is laying on that shoulder. It's overhead pain. It's just kind of a dull toothache. It's achy. That usually, like I said, that's 99% of the time we'll treat that with either medicine or a cortisone shot, and it gets better 99% of the time without surgery. It's very, very rare. The typical times I'm doing any surgery with impingement syndrome is it's somebody who looks like on their MRI has a rotator cuff tear. They've had conservative treatment. It hasn't gotten better. We get in there, their MRI was a false positive, and we just doing the bone work. And these people do well, but that's probably 2 or 3 times a year out of 250 shoulder surgeries. So it's rare.
Okay. Do you recommend any preventative shoulder muscle or tendon building exercises? I'm assuming it's probably these that you just discussed.
The ones I just discussed, absolutely. Those
Okay.
little weights, high reps. You don't have to go crazy with them. Those are the best ones.
Can you talk about acromioclavicle joint degenerative?
I'll handle it.
You got that
Mild
one.
acromioclavicular joint degenerative arthropathy. Is that likely to progress? So as I always make a joke, I try to experience all my patients ill. So I have dislocated, as I said, my shoulder 3 times. I also have had a grade 2 AC separation. Now I have pretty severe arthritis in that joint because it's been 35 years since I did it in college. So it will probably progress. Don't worry about the bump. As long as it doesn't hurt, I wouldn't even worry about it. If it hurts, typically we can do anti-inflammatories or cortisone shots. I didn't really talk about AC joint arthritis too much in this talk, but if the treatment is very similar to impingement syndrome, cortisone shots, anti-inflammatories. If it doesn't work, we go in there arthroscopically and basically shave out the arthritis, and then the bones don't touch each other anymore, and that gets rid of the arthritis and takes care of the problem. So.
Great. I see a couple questions in here about PRP, and I know you touched on
Sure.
it briefly, but maybe just a little bit more detail about your thoughts on PRP for shoulders.
Yes. So PRP in shoulders is a reasonable option. I actually just saw a patient yesterday. I did it on both shoulders for him. He has rotator cuff tendinopathy, wanted PRP. It is not covered by insurance. So it has to be paid for out of pocket, and that's going to be probably for the foreseeable future. It does seem to help improve the milieu or the environment for the rotator cuff to live in. Whether it's a long-term solution, I'm not sure. The jury's still out on it. There are some reasonable studies more in the knee than the shoulder. They have looked at it for rotator cuff repair. So basically doing a PRP injection after doing a rotator cuff repair. I would have to say that half the studies say it's better, helps. Half the studies say it doesn't help. So to me, that's not definitive documentation or data. So I don't do it. Like I said, I just had the patient I did a revision on about 2 months ago. We did a biologic on her, but because I really thought, and she was 75, I thought we really need to do something to help jumpstart the healing process because I think her repair just didn't heal. It was a small tear. It should have healed. It didn't for some reason. So I had to do something to change the environment in that shoulder. So that's where I think PRP 2025 was shoulders.
Did it help her?
So far she's doing. I mean, I don't want to ever jinx it, but so far so good. I think if it heals the rotator cuff, the answer is yes. So yes.
Great. How serious is an anterior labral and a slap tear?
It depends. If you're a 21-year-old college football player, it's very serious. If you're a 65-year-old weekend warrior like myself, or 55-year-old weekend warrior, it's not a big deal. Like I said, I've lived with one for 40 years, and I play pickleball 2 to 3 times a week, and I don't think twice about it. I have other ills that affect my pickleball game that are not in the shoulder. So it depends who you are. So if you're above 45, it's probably not a big deal. If you're under 45, it might be a big deal. If you're under 25, it's likely a big deal. So we typically go surgically in the younger patients and in the older patients, adult patients. We typically will, if we have to do something surgically, if we're going in for a rotator, we'll just clean up the labrum. We're not going to repair them unless somebody has a frank dislocation at 55 years old. And that typically is not going to be a labrum tear. That's typically going to be a rotator cuff tear.
Okay. Bands versus weights.
I don't think it matters. I happen to be a weights person myself, but bands are just as fine as long as they give you the equal resistance, whichever you prefer.
Is there a procedure to deaden nerves shoulder pain site for seniors over 80?
Not to my knowledge in the world of orthopedics. Some of the pain management doctors will do some sensory nerve deadening in the shoulder. It's a little out of my realm of expertise, so I would say I wouldn't comment on it, but I have heard of some people having sensory nerve, but unfortunately, most of the nerves that run through the shoulder are motor nerves, and you can't really deaden those, but there are some sensory nerves you can try to go after in the shoulder from a pain management standpoint.
Question about CT. When would contrast be used with the MRI? Thoughts on CT with contrast versus MRI?
Yeah, so we'll typically use MRI with contrasts. It's funny you bring that up. I have a patient coming in tomorrow with that. So typically we use MRI with intra-articular contrast. We call it arthrogram. I'll use it for a high school or college athlete that has a dislocated shoulder. So for example, I kind of got burned on one. It was an in-season football player where I did a non-contrast MRI. He clearly had a dislocation by exam, but the MRI didn't really show what I wanted to show. So we sent him back for the arthrogram. He's coming tomorrow. He has a labrum tear and a loose piece of cartilage floating around the shoulder. So the arthrogram picked it up, but the plain MRI didn't. So that's where a good time to use that arthrogram. CT is good for fractures. CT arthrogram would be for somebody who has a pacemaker that is not MRI compatible. So in that, we're looking for a quantitative or I should say qualitative diagnosis, where if I see dye passing through from the shoulder to the rotator cuff space, then we're going to say there's a rotator cuff tear, but I can't say how bad a tear it is. So that's usually when I use CT arthrogram is for people with pacemakers or defibrillators that are not MRI compatible.
Great. Does age determine the type of surgery? Dealing with a 97-year-old mother-in-law who has arthritis and tears. Her doctor said she is healthy for surgery if needed.
Yeah, I mean, if she can clear her cardiologist and clear her medical doctor, and I mean, I had a grandmother who lived to 99 and was living a good life up to that point. They would probably do a reverse shoulder replacement for that situation with arthritis and rotator cuff tears. But it's there's, like every surgery, there's a risk, so you have to weigh the risks and benefits. If you can get by with non-operative treatment for a 97-year-old mother-in-law, I would strongly recommend that. But if she wants surgery and the doctor's willing to do it and she's feeling okay with it, then go right for it.
Do you stay away from overhead weighted exercise if there's some rotator cuff as well as bicep tendonitis issues? Not a
Uh,
full thickness tear, no significant pain.
yes. So I tell all my patients so for example, my neighbor who I just mentioned previously, who's the trainer, I gave her a shot. She called me 2 days later, said she's feeling great. So I said, my rule of thumb is see your hands for your exercises. So this is my mentor taught me this one. So if you're pressing and curling, you can see it. When you start going up here and back here, that's where you can get in a lot of trouble with overhead activities. It puts you in that pinching position. So military press, skull crushers, lat pull downs behind the head. You can do incline press is usually okay, but you really want to see your hands. Flies way back like this. You want to do your flies here, that kind of stuff. You want to avoid that. I should probably practice what I preach for myself. I don't necessarily always follow that based on limited equipment that I have in my basement. But you really should try to stay away from overhead and behind the activities if you have any kind of rotator cuff or biceps problems.
I like that piece of advice about seeing
Yeah,
your
very,
hands.
very simple. Yeah, and I tell that to all my patients that I
Yeah.
either take care of or operate on.
Yeah. Wonderful. Well, I think
Good.
that was it for the questions. Oh, we're getting a couple compliments. Very well done. We got a couple
Thank you.
thank yous. This was super interesting. I learned a lot. I'm hoping everybody else did. Thank you so much for taking your time, and thank you to everybody who joined us. I hope you got some good information. I did put my email and my phone number in the chat. It's also in all of your emails. If you would like to schedule an appointment with Dr. Hornstein, have another question, you can always reach out to me directly. And I'll say it again, thank you so much for your time.
Thank you all for your time. Appreciate it.
Alrighty, have a great night.
Good night, everybody.